Good afternoon, ladies and gentlemen. Our next speaker is Dr. Ronnie Tan, who's a urologist at Mount Elizabeth Hospital and Parkway East Hospital. He subspecializes in andrology, male subfertility, sexual medicine, and urological prosthetic procedure. And in addition, he does lots of urolift procedure. The next topic is SMHS lecture on the effect of COVID on men's health. He's the most appropriate person to speak on this because he's the current president of the Society for Men's Health, but more importantly, he has come up and close and personal with COVID, and he can attest to the effect on this man's health.
All right, thanks, Cockit. I'll show you my health is still quite good. All right, just want to thank everybody for staying back till the end for our SUA SMHS joint session on andrology. So I was involved in UROFAIR 2020 as a scientific chair. Initially, we planned for a physical meeting, and then COVID hit, so we had to switch to a virtual meeting. Initially, we were discussing whether not to do it, but then we did it, and the virtual meeting was good. And then I was tasked to be the organizing chair of last year's UROFAIR. At that point, we were not sure whether we'll do hybrid or we do Zoom, but I think we went ahead with the virtual, and I hope everybody was happy with it. And then this year, it's wonderful that we can actually meet in person. And I think Fiona and the team has really done a good job. And then I also want to give a shout out to Weda for giving me this topic. Okay, so this hybrid UROFAIR, I think, has been wonderful, right? So I was able to attend the meeting yesterday virtually, and I was still able to run my clinic. So today I'm attending the meeting physically, partly because I have to give this inaugural SMHS lecture. So I was telling some of my colleagues that it's been a while since I have to prepare my talks from scratch, because usually the topics that I have will be the topics that I usually talk about, and then basically we just make it nicer and nicer, more slick, add in more of the updated thing. So this round I have actually had to do a lit search. Yeah, it's quite painful, but must thank Weda. Yeah, so I guess I only have myself to blame because I agreed to give the talk even before he gave me the topic. So anyway, it was I had a good time yesterday catching up with friends and colleagues at the faculty dinner, and then I have to work till the 11th hour last night to get the slides up because we had to submit the slides first. But the script, I have to change it a bit. Okay, enough. That will take a few minutes. Okay, so studies have reported that the effect of COVID-19 on men is actually more severe than in women. So what do I mean by that? It has been reported that the ratio of men contracting COVID compared to women is the factor of 1.03:1, with the higher ratio of reaching 1.37:1 for those aged 70 to 79. It's found that men also tend to need ICU management more than women. Some attribute that to the fact that men tend to have more chronic comorbidities when they're older compared to women. Some also attribute the fact that the risk perception and handling, claiming that women in general are more likely to adopt or practice non-pharmaceutical behavior. That means they tend to wash their hands more than men, they use sanitizers, they wear masks, and they're more compliant to being quarantined. So this is a slide which shows that there are actually more men dying from COVID compared to women. Some studies have shown that we cannot just attribute this to the fact that men possibly can have chronic comorbidities. Okay. I'm not an infectious disease physician, neither am I a virologist. I'm just a humble andrologist, so just bear with me. From my reading in preparation for this talk, thanks, Dr. Lau, the mechanism of viral entry for the SARS-CoV-2 is actually dependent on these two receptors, namely ACE2 and TMPRSS2. So the spike protein on the virus binds to the host ACE2 receptor, and the host TMPRSS primes the spike protein as cellular proteases cleave the spike protein into your S1 and S2 subunits, and then the viral RNA is released. Yeah, suddenly I sound very intellectual, right? Yeah. But I'd like to remind the floor that this is a SMHS lecture, which is a name lecture, so later, please do not have any Q&A regarding this part. Okay? Yeah, ACE2 is actually located on the short arm of the bar zone of chromosome X, on the locus XP22.2. So men tend to be hemizygous for this ACE2. Increased ACE2 expression is seen in women, and this is found to be protective against severe symptoms in general. So ACE2 actually protects against your vascular compromise and severe organ damage. Hence, once the virus binds to the ACE2 receptor to enter the cell, the protection is gone. TMPRSS2 is associated with androgen sensitivity, and the lower levels of androgens in women lead to a lower cellular expression and hence less host receptor for the virus to bind to. There was actually a case series from Netherlands that reported 4 healthy brothers who had to be admitted to ICU for severe COVID-19 symptoms, and all found to have loss of function variants of toll-like receptor 7 gene, which is again found on chromosome X. Looks like men have gotten the short end of the stick with regards to COVID-19. We all know that male reproductive organs can harbor viruses, or rather the viral infection of the reproductive organs is common. For example, things like CMV, HIV, mumps, Zika virus. This is a nice schematic that shows how infection by COVID-19 can result in epididymitis or bronchitis. Also, the psychological stress and the antiviral drugs used to treat this disease can in turn cause oxidative stress and affect the Leydig cells and the Sertoli cells, resulting in low testosterone, disrupted spermatogenesis with sperm abnormalities and DNA fragmentation. Binding of the SARS-CoV-2 to the ACE2 inhibitor, ACE2 receptor at the endothelial cell surface can disrupt the endothelial signaling, and this can lead to endothelial injury, leading to erectile dysfunction. On top of that, psychological stress can also result in decreased sexual desire and also low testosterone due to the effect of oxidative stress on the Leydig cells. Okay. This is a slide that shows the detection of the virus in penile tissue. Okay, this slide shows the immunohistochemical comparison of the endothelial nitric oxide synthase. So the one who is COVID positive had less intense staining, indicating relatively low expression of eNOS, which indicates the endothelial dysfunction and damaged vascular integrity. In case you were wondering who would allow a study to take penile tissue from men already suffering from COVID-19, so this tissue from the cavernosal tissue was actually obtained from men who were already planned for penile prosthesis placement. So they compared those that were previously infected with COVID compared to someone who doesn't. So it shows that it does affect the endothelial function. Yeah. So this is a systemic review and a meta-analysis of the andrological effects of SARS-CoV-2 infection. So you can see from here, there is a drop in sperm count, sperm concentration, motility, as well as semen volume. We find that even the serum testosterone levels have been shown to drop in these cases. So these are some of the common complaints that my patients report. A lot of them will come to us saying that they have ED, decreased sexual desire, libido, difficulty with arousal, or even subfertility in those patients who have had COVID. All right. Of course, we know that these conditions can also occur because of the fact that they are under a lot of stress from the infection itself, general unwellness, prolonged isolation, yeah, can also play a part in this. And we know that because of the pandemic, those who do not have COVID-19 are also affected. Because of this, patients who want to seek us for men's health, they are also affected. Because we know of the policies to delay all andrological surgeries and consults, as these conditions are deemed to be benign and non-life-threatening. So at the height of the pandemic, a lot of these men were actually postponed indefinitely, both in the private sector as well as the public sector. So I personally had a patient who recently saw me. He stays in Malaysia. So he went back to Malaysia because he couldn't decide whether he wanted to do his Eurolift. So the day after he left, borders were closed. Yeah, so he never got to do it because it's not life-threatening. Yeah. So men who are planning to do things like varicocelectomies to deal with fertility also had to wait. And we know that in many cases, I have these couples who say that actually they don't mind waiting because at the point where we are not sure of how COVID will affect fertility or actually affect the germ cells and things like that, they're actually worried that should they have a kid during the COVID, whether there will be any long-term effects on the child. So some of them actually started to use contraceptives. Okay, and then men with Peyronie's disease, of course, they had to wait. Just can't be straightened out so fast. And those planned for penile implants will also have to wait. So even now that measures have softened, we know that we have to test the patient with the ART positive, right? So we have patients who actually turn on the day ART positive and turn them away. But then I guess we have to do that. That's just the way things will be different from now on. So you would actually think that because of all this decreased social activity and social distancing, that couples will be more active. But then they've done a study who showed that people are actually having less sex because they are fear of infecting one another. They are depressed, anxiety, and also stress. Sometimes being cooped up in a small place. So although you may not need a lot of space to have intercourse according to our minister, but sometimes, yeah, it's just the stress that affects them. The APSSM actually came up with a position statement about the provision of sexual medicine services during the pandemic. So recommendations include doing teleconsults, webinars, of course prioritization of surgical cases, the optimization of medical therapy, and to discuss with colleagues how long these treatments can actually be deferred. And of course, infectious control measures should these patients actually go ahead and do surgeries. Okay, this paper shows the examples of sexual medicine patients who are suitable for teleconsult and those who may not be suitable. I think it's quite straightforward, the ones that are not suitable. I mean, if the patient is intoxicated, I mean, he needs to be examined and all that. Of course, we can't do that. So it's relatively straightforward. I would say most of it is quite common sense. So I'm sure by now we are all quite comfortable with the teleconsults. In my practice, it has been really helpful for follow-up patients, both local and overseas. So I also have new patients who have teleconsult as a second opinion. And now that the borders are open, it's actually quite good because these patients can actually do a teleconsult to ask about the surgeries that they want to do before actually making the step to come forward to travel over to Singapore to do it. But at the end of the day, the inpatient consult is definitely what we all want, as physical examination is still an integral part of the consult. Not to mention the rapport that we build with the patient, especially in the field of sexual medicine, andrology, and men's health. So I believe the experience we get from pandemics like SARS and COVID should cause a paradigm shift in the way we look at disease. Some benign diseases still need adequate care and should not be postponed indefinitely using a blanket rule. And many non-cancerous chronic diseases still have to be treated, and non-COVID patients are still patients who deserve the care that we owe them and the treatment that we can provide. Thank you.
Oh, that's an excellent talk by President of Society for Men's Health, Dr. Ronnie Tan. So I'm still not very sure whether you were honest about how healthy you are after COVID, but I think we'll leave that to tomorrow's dinner. So moving on to the next speaker, Dr. Ian Eardley, and that's going to be a Zoom talk being delivered from UK. So do we have the connection yet? Great. So the next talk is on penile lengthening during implant surgery. Evidence-based or myth. So let's give a brief introduction to Dr. Ian Eardley. So me and Ian go back a long way when I did my fellowship in endourology, and I stole some fellowship time to do andrology. So Ian's been big in UK medicine academia. He played a huge role in the Royal College of Surgery, and he's actually still actively practicing in St. James Hospital. Dr. Lau Wei Ta also went to do a fellowship just a few years ago, in prosthetic surgery and urodynamics and reconstruction. So Dr. Ian Eardley is well known. He's from St. James Hospital. trained in Cambridge, and he interested in the areas of andrology, genital reconstruction, and he is now the chairman of the council at Medical Protection Society. So that's a very important topic in medical legal practice today. So without much further ado, thank you, Ian, for giving this talk. I think it's a good time in the UK. Our time difference is not too different. So thank you very much. So give us your best shot.
Good morning, Colin. Lovely to see you again. Thanks to you and to WIDA and the organising committee for asking me to give this presentation. And hopefully we'll get to meet face to face before too long. I've been asked to give a presentation regarding penile lengthening during penile implant surgery and whether it's really possible or not. A couple of facts, I think, to begin with. The first one is the erectile dysfunction is often associated with loss of length. I think all of those members of your society in the audience will know that there is corporal atrophy that develops when the penis does not become erect on a regular basis. It's probably due to loss of smooth muscle within the cavernosal tissue in replacement by fibroblasts. But again, there's good evidence of loss of length following radical prostatectomy. We know that people lose length is often one of the major complaints of patients with Peyronie's disease, with hypergonadism, and for those patients who have radiotherapy, particularly for prostate cancer. So men with ED often have smaller penises than they remember. When you put an implant in, again, there's really good evidence that what you do is you are able to maintain the stretched penile length. You don't maintain the erect length that the patient would have had when they were a young man, but the stretched length before and after implantation is the same. The difficulty for patients is that the stretched length is about 1, perhaps 2 centimeters less than the erect length. And that creates a few problems. Because conventional penile implant surgery doesn't give an erection that's as long as a normal penile erection, patients are often disappointed because we all know that to some extent size matters, and they do not have the erection that they perhaps aspire to, that perhaps they remember. But there's an additional problem. Even when you explain to men beforehand what's going to happen, even when you demonstrate that the stretched length is the same before and after, a majority of men still think that it's smaller. And part of that is because of aspiration, part of it's because of the angle in which they look at the erect penis. But this issue of perception is a difficult one to treat. So, given that problem, surgeons have looked at ways whereby they might be able to maintain or increase penile length before, during, or after penile implant surgery. And if you review the literature, this is a list of the approaches that people have tried, and I will work my way through them one by one, moving through a preoperative use of vacuum erection devices, through the perioperative, intraoperative approaches, some of which are superficial, some of which are cosmetic, but some of which are very real surgical attempts to increase penile size. And then looking at postoperative approaches, which primarily is around cycling of the device. I should say at the outset that the evidence base is not a strong evidence base. There's most of the data is single center, often single surgeon. But there is a little bit of more robust evidence. So, for instance, this was a randomized control trial. It was a small trial, only 51 men, and the men were randomized to either receive regular use with a vacuum device preoperatively versus not using it at all. And it provided some evidence that preoperative use of a vacuum device does provide benefit over doing nothing. And I think increasingly surgeons, certainly in the UK, are doing this pretty routinely in their men who are on their waiting list for a penile implant. And you can see that numerically in this study, there was about a 1 centimetre benefit for those who used erection devices. Moving to intraoperative approaches, the first thing you can do is just try and put in a bigger implant. And it is interesting that if you review company data from the two major manufacturers, Coloplast and Boston, they will tell you, and they will be able to show you, that the size of the implants that are going in are bigger than the implants that were going in 10 years ago. And this is particularly true in the USA. So they're getting increasing use of 20 and 22 centimeter cylinders and a decreased use of 16 centimeter cylinders. So surgeons are trying to put in bigger implants. There was a small prospective uncontrolled study, Gerard Henry, published Journal of Sexual Medicine 10 years ago, where he talked about what he called a maximum aggressive dilatation technique, whereby he would really go for it. Clearly there are risks with this. There's increased risks of distal perforation, there's increased risks of proximal perforation, but he used these techniques and claimed in a small study, I think it was only about 12 or 15 patients, that there was a potential benefit in terms of getting larger implants in place. The devices, the companies have actually tried to help with this. So again, Boston have an expanding implant. We all know that the inflatable implant produces good girth, it gets good girth expansion. But the Ultrex device that was introduced in the 1990s, I used it many years ago, potentially gives a 2 centimeter increased length with longitudinal expansion during inflation. The cylinders weren't particularly robust. I was always slightly worried about the risk of erosion, but objectively what people found was that the cylinder life was diminished and there was an increased risk of an S-shaped deformity. And so a variety of technical and technological changes were made to the Ultrex device that led to the production of the LGX implant, which again, in theory, gives an expansion in length of about 1.5 centimeters. Interestingly, although there is some data in the literature, some of the data is not positive. That study from Gross et al. In the Journal of Sexual Medicine show that actually only about a quarter of the men found that the length was maintained and that there was a mean loss of length of 1.3 centimeters. So the results with this expanding implant aren't perhaps as good as one might hope for. There are cosmetic approaches to try and make the penis look bigger, whether it's a suprapubic lipectomy, whether it's a ventral phalloplasty. I suspect that most of the people in the audience will be familiar with these approaches, which are potentially of value in people who are overweight or who have a high riding distal scrotum. But obviously this is not actually changing the size of the erection itself. Moving on to the more aggressive approaches, this was the first, I think, of the really aggressive surgical approaches that was published in 2012. Multiple authors, so David Ralph from UCL was one of the authors, one of the surgeons, and you can see that the surgical technique is pretty aggressive. It involves mobilization of the dorsal neurovascular bundle. It involves mobilization of the urethra. It involves a circumferential incision of the tunica albuginea, with the penis being then stretched out to length and a graft put in place. You can use whatever graft you want. For this sort of size graft, you tend to have to use the commercially available grafts, and I think they were using pericardium in this study. And you can see that from the photographs that potentially you could get a significant improvement in length. This initial paper was really confined to men with Peyronie's disease, and I'll look at some of the results a little bit later on, once I've got through the techniques. The next approach, and there's a variety of these, what you might call the slicing or sliding techniques. The first of these was described about 10 years ago, and is a longitudinal tunical incision with a couple of circumferential incisions at either end of that. Again, requires complete mobilization of the dorsal neurovascular bundle and of the urethra, and then you put the penis under tension, and then you create areas that you can graft at either end. Again, this initial approach with the sliding technique was confined to Peyronie's disease. Dr. Egidio has then moved on to describe a number of different approaches which do not involve grafting. Similar sliding technique, a modified sliding technique, and a tunical expansion technique, all of which are designed to increase the penile capacity and increase the tunical length to allow a larger implant to be put inside. And these are some operative photos of the very first sliding technique you can see on one side of the screen, whereby there's been a longitudinal tunical incision with a couple of circumferential incisions, leaving the spongiosal tissue intact, the urethra intact, the neurovascular bundle intact. The implants are put in, and in the original description, they would be covered with a graft. Any of you who's tried to do these techniques will know that this is a lengthy procedure. You can't put in a quick implant doing this, and the longer the procedure, in my experience, the greater risk of implant infection. So we'll look a little bit at the results in relation to that towards the end. On the other side of the screen is the most recent of Dr. Egidio's approaches, whereby he's moved from these big single longitudinal incisions to multiple releasing incisions in the tunica, which with the multiple incisions, which he does not graft, it allows the penis to be pulled longer and allows longer insertion of a longer penile implant. So what about the results? Well, this is a summary of the results. Most of them, as you are effectively single center results. The first one with circumferential grafting, Dr. Sansalone's paper. Average length gained, about just under 3 centimeters. Some loss of gland sensitivity, as you might expect, with the mobilization of the neurovascular bundle and a residual curvature in a few patients, but no suggestion of a gland's necrosis and no suggestion of penile implant loss or infection. The initial description of the sliding technique, Dr. Roller, published 2016, again confined to Peyronie's disease, again 3 centimeters improvement. The morbidity reported in the paper was confined to a single case of an infected implant. They did not report on gland sensitivity. The 3 Dr. Egidio techniques, you can see much larger series, all of them potentially getting 3 centimeters in length and remarkably little morbidity. So only one implant only one infected implant in all those cases, only one case of glands necrosis, and a decreased gland sensitivity rate somewhere between 2 and 5%. I think the worry is that some of these complications and risks are being unreported. And Steve Wilson got together with a number of significant implanters a few years ago to pool their analysis of patients who developed glands necrosis after penile implant insertion, looking at the risk factors. And the photographs on the screen show a case where you move from progressive ischemia to necrosis to erosion of the implant through the necrotic distal penis. And you can see this would be an absolute catastrophic disaster for the patient. The risk factors they found are vascular risk factors, essentially, atherosclerosis, diabetes, smoking. But previous implants, again, a risk, previous radiotherapy, a risk, and in their experience, also risks technically with the use of a subcoronal incision, presumably because its effect upon the blood supply of the glans penis, the use of a sliding technique, and the use of occlusive dressings. And most people who put implants in these days do tend to use occlusive dressings post-operatively, at least for 24 hours or so. So moving on to the post-operative approaches, again, we come back to Dr. Henry, and he tends to combine his aggressive dilatation with a pretty aggressive post-operative cylinder cycling approach, where it's daily inflation for half an hour to an hour, for 6 months and then continuing with maximal inflation for up to 12 months. And he's produced data in an uncontrolled study that suggests that the length of the implant improves, or the length of the erection improves over the 1 year post-operatively, which presumably means he's got to put in bigger implants, but he is getting a 1 centimeter increase in length over that 12-month period. So, what's my perspective on that? The first one is, I think, trying to treat a male cosmetic wish and perception and desire is often difficult to treat surgically, and that you need to do it with a degree of caution if you're going to go down this track. The second observation is, I think the quality of the evidence is poor. Most of the reports are single center or single surgeon. Most of them are in decent quality peer-reviewed journals, but the results have not been reproduced in other centers, and I think that is always a worry. And anecdotally, if you talk to people who've tried these techniques, the risks of surgical lengthening are perhaps underreported. And as I showed you in the case here with the glands necrosis, can be potentially devastating. So in trying to give an objective view, I've tried to use what the European Association of Urology might use in terms of the strength of their conclusions and recommendations. I think there is really good and strong evidence that erectile dysfunction is associated with loss of erect penile length. I think there is strong evidence from multiple studies that penile implantation properly done preserves stretched penile length, but does lead to a loss of the erect penile length that the patient might have had as a young, potent man. I think that there are a variety of perioperative strategies, preoperative and postoperative, which have been reported to maintain erect length with minimal complications, and that within that I would include the vacuum devices, the maximal sizing, the use of the lengthening implants, and the post-operative cycling. I think the evidence is still weak, and the recommendation that you can make from that, I think, is weak as a consequence. Then finally, I think there are a number of surgical strategies that have been reported in a few centres whereby there is a potential for very significant increase in penile length. They are in only a few centres, they are in only 1 or 2 surgeons, and I have to say I still have a worry that the morbidity is underreported. And by that I mean relating to gland sensitivity, glands necrosis, implant infection. So I think, to summarise, we're partway along the track. In my own practice, I tend to do what I can in the third strategy regarding the perioperative strategies, the use of devices, the use of trying to get the patients using these devices early and using them regularly in order to maintain as much length as possible. I worry enormously about the reported surgical strategies within the surgical literature, and I'm very struck that surgeons who I respect and who are high volume implanters such as David Ralph or Steve Wilson do not subscribe to the sort of surgical strategies that I showed, the slicing and the sliding techniques. Thank you very much for inviting me to speak, and thank you very much for giving me time to talk to you today.
Thank you, Prof. Lee. Next, Prof. Wang Run do not require additional introduction. He has vast experience with implant surgeries in complicated patients and difficult situations. Let us welcome him again so that we can benefit from his vast experience.
Thank you. If you are a serious penile implanter, you're going to like this talk because I'm going to give you a lot of tricks that you didn't know about how to prevent the infection for patients with diabetes. And Ronnie talking about COVID-19 affect mental health. And one thing he did not talk about was that many people has COVID-19, they lost their penile implant as well. The reason for that, they get sick, they stay in the unit, they put a catheter in, and they don't care about what happened. If you got a penile implant with a catheter for a long time, you lose your penile implant. So we published that. So for some reason, Ronnie did not see that paper. So the task I gave by Wida was to talk about diabetes patient with a penile implant. We know that if you are talking about everybody who has erectile dysfunction, the diabetes, I used to say, is the #1 killer to your penis. So actually the vascular is #1, but diabetes also causes vascular problem as well. And for patient who has a penile implant surgery, that diabetic patient is occupied probably about 1/5 of those patients who get the implant. So diabetes is a big issue in our penile implant business. How can we make the best outcome for patients with diabetes is to prevent infection. Second, prevent infection. Third is also prevent infection. So we're going to talk about very quickly about the risk of the diabetes for patient to receive the penile implant. And in general, if you're talking about the comparison of the patient with diabetes versus no diabetes, the risk was not so high. It's about 1.8 versus 1.3. However, if the diabetes patient received the implant with antibiotics coating versus patient did not receive the penile implant with antibiotics coating, then the risk become big difference. So non-coating device with diabetes, the infection rate is somewhere about 4.2% versus the patient, they use the coating device was like about 1.6%. So it's a big deal. Another thing is that if you're talking about a patient, the blood sugar on the day of the surgery, there is a study showed that if the patient's blood sugar is more than 200, there is about 5.4 times higher risk to get infection. And if you look at the patient's hemoglobin A1C level with a penile implant, so obviously if the patient's hemoglobin A1C more than 8.5, which will significantly increase risk of infection versus patient has less than 8.5. In my practice, I want two patients' hemoglobin A1C level less than 7.5 before I do surgery. And unfortunately, there's data still controversial. If you look at this meta-analysis, very strange. Only one paper included in this meta-analysis. They did not find any difference in terms of the hemoglobin A1C. And also, if you look at the patient's blood sugar the day before, on the day of the surgery, a patient had infection versus patient do not have infection, there's no statistical difference at all. However, remember, pay attention to those numbers. The average the blood sugar in this patient is 140 something, and average hemoglobin level is also 7 point something. So this is not the extreme picture for this patient who has severe diabetes. So again, and what is the best way to have a best outcome for patient with diabetes for the implant? The infection prevention. So I'm going to go very quickly about our strategy, pre-op, intra-op, and post-op. And in terms of the pre-op strategy, and first thing we need to talking about the shower. We always tell the patient you need to take a shower for 3 days before you come in for the penile implant surgery. And the recommendation we like to give the patient is to use chlorhexidine shower. But the bottom line is that if you look at all this publication, this data are from the surgery unrelated to penile implant. We have not done a very good job in this arena in terms of the science. Most of this information comes from the other surgery, especially orthopedic surgeries. So overall, if you compare a patient has taken the chlorhexidine shower versus patient taking no shower, taking the shower with the regular soap, there's no significant difference at all in terms of surgical site infection. However, we believe the chlorhexidine is very cheap and very easy, so we always encourage patients to do it before the penile implant surgery. Another thing is about the glycemic control. Again, I mentioned earlier, the data are controversial. My recommendation is that make sure the patient's hemoglobin A1C is less than 8.5, but in my practice, I want the patient get less than 7.5, and also the morning glucose less than 200. What about the pre-op IV antibiotics? The AUA-based practice published many years ago. And then in 2018, the AUA guideline again emphasized the best option to use antibiotics is vancomycin, or first or second generation of cephalosporin, and plus the gentamicin. And the antibiotics should give 1 hour before the surgery. And the problem with this is that if you look at the coverage of those antibiotics for the patient, we can tell you that some patient, for example, patient with the fungus, some patient has the anaerobic bacteria, these are not covered by those antibiotics. The AUA guideline and the EU guideline, and if you use that ICU antibiotics guidance, is about 14 to 38% of the cases, these antibiotics did not cover the bacteria. So therefore, in our practice, if the patient has obesity, has diabetes, if it is a redo surgery, the recommendation is to use vancomycin plus the gentamicin plus the antifungal medication. And what about the hair removal? And again, the data is from the surgery unrelated to penile implant. And we know that if you use the razor compared to clipper, there's a pretty higher chance to have the skin injury and has increased the chance to have surgical site infection. Therefore, the recommendation is to use the clipper on the day of the surgery, because if you had the hair removed the day before surgery, there's a little bit higher risk of skin surgical site infection. What about the skin prep? And again, the data is from the publication unrelated to penile implant. We learned this mostly from the orthopedic surgery. So use the chlorhexidine alcohol-based appears to be much better than you use the betadine-based. And so recommendation is to use chlorhexidine alcohol scrub. And what about hand wash for surgeon? Again, the data is also unrelated to penile implant. The bottom line was that it appears that you use alcohol-based scrub or rubbing, which will have better results compared to use the traditional way. You wash your hand 10 minutes and use the betadine. And what about the surgical time? And again, the data has come from the orthopedic surgery and systemic review and meta-analysis clearly show that the longer of the surgery, the higher chance where patient will get a surgical site skin wound infection. So when we do surgery, try to be proficient. And of course, we don't need run the race car, but you need to be efficient. And what about the operating room traffic? And the data clearly show that if you have people going in and out in the operating room, there is a pretty high chance to increase the infection. And at each nurse turnover, there is about 9% increase of the surgical site infection. And what about double gloving? And double gloving is very important in penile implant business. So if you compare the patient with the double gloves versus patient only have a single glove, and the second pair, inside pair of the glove, by the double glove, the surgeon has significantly less chance to have a perforation than the single glove. So recommendation for penile implant, use double glove. What about the glove change? And the data also unrelated to the penile implant. And very important for you to remember is that if you do not change the surgical glove and one time goes, there's increased chance of the infection. So recommendation is that, so change the gloves every time before you touch penile implant, or if your surgery past 1 hour, remember change your glove. And I do not know how efficient you guys are here to do penile implant. And in our center, most of the time the penile implant surgery is done about 30 minutes. So therefore, we do not need to change gloves in terms of timing, but we always like to change gloves when we touch the penile implant. What about intraoperative strategy? And lung touching technique is recommended. There's data clearly show that if you do the lung touching technique, you can further decrease the chance of infection. So this is basically my standard when I do this procedure. Actually, it's very easy to do with the IR band. What about the antibiotics coating inside the for the penile implant? There's no doubt. We do not need to debate. The antibiotics coating will decrease the infection significantly. Only the one report is outlier for some reason, and the Coloplast is not antibiotics coating device, it's a hydrophilic. So if you soak the implant into the antibiotic solution, that will be considered as the antibiotics coating. So in the United States, we did a study, our society did a study, SMHS member versus non-SMHS member in terms of antibiotic irrigation during the surgery. Our member appears to use the irrigation more common than the non-member. And however, there's no consensus which kind of antibiotics should we use for the irrigation during the penile implant surgery. Right now, I don't know you have this available or not in the in Singapore, and it's called UROFAIR, and which is chlorhexidine-based irrigation. It's very cheap, and you don't have to mix with any antibiotics. It's pretty effective. So that is our switch. I think you're going to have more data coming up in the next few years regarding this irrigation. And what about the dressing? And Henry compressive dressing is obviously recommended in most of the penile implant procedure. And I use this coffee cup to cover the penis as well. So because I routinely leave the penile implant about 60–80% after the procedure. Number one, for decrease the chance of hematoma. Number two, also to try to keep the size during the patient's healing. Therefore, I use this cup to to protect the penis in case somebody touches the penis. It will cause discomfort for the patient. What about drain? And the drain is also controversial. You will hear this talk almost every other year in the AUA, during the AUA or during our society, Sexual Medicine Society of North America meeting, and half of the surgeon will use drain, half of the surgeon will not use drain. So you have freedom to do either, and I have never used drain, and I have not been using drain for 20 years, so I will not use drain. I will continue not to use drain. And I think the drain will increase the cost, also can have a potential problem with drain place, because you need to remove the drain. You have the resins to close the wound. Sometimes the drain will get stuck with the stitch. What about the post-op antibiotics? Again, there's no consensus in the United States. And if you're talking about our member versus non-member, and it seems like our member tends to use post-op antibiotics more than a non-member. And there's no consensus regarding which kind of antibiotics we're supposed to use. But however, it seems like Levaquin is one of the most common antibiotics we use. And this is my last slide. I did it very quick. I almost covered everything we can in terms of how to prevent infection during the penile implant surgery for diabetic patients. I hope this is going to be useful for your practice. Thank you very much for your attention.
Very thank you. So we're going to move into a short Q&A session. So I'd like to invite all the speakers to the stage and as we take questions.
Is there any question from the floor to our speakers? All right. Okay, I'll just start off first. Yeah, COVID-19 has been a disaster for endocrinological surgery because it is considered non-life threatening, completely elective surgery. There's no impact on the health of the nation in general. Okay, so Ronnie, I sympathize with you, right? So as for telemedicine, right, do you have any experience or any interesting anecdotes to share regarding about, treating andrological conditions through video conferencing as such? For example, patients trying to demonstrate their Peyronie's disease in front of the camera to you.
Okay, so I was not that fortunate to have someone flash his phallus in front of me on the teleconsult. So that's not an issue. One of the things that I felt was can be quite annoying was I had a patient who he had the teleconsult for erectile dysfunction, so he's relatively young. So when we started the consult, I was using this third party, went through another company to actually do the teleconsult. So he said that he was very shy, so he didn't want to show his face. And then after that, the consult took relatively long, so it was about an hour. I happened to be free because, you know, less patients, right? So talked to him. At the end of the day, the problem was when the company tried to charge him, he actually gave us a fake credit card number. So yeah, so sometimes it can be con in terms of teleconsult. Just have to be careful.
Also, we have a question from the floor by the famous Professor Lim.
No, just a comment to Professor Ron Wang. Now, I did a paper some time ago which compared the infection rates in low number of implants surgeon and those who have done a lot of implants, and those who have a lot of experience with implants had a lower infection rate, which is a simple way rather than the elaborate way you have done, which is of course very informative. But the more experience you have, the less chance you're going to get an infection. In my experience, the other thing is also when you do this implants is the type of patient you're implanting. So the selection of the patient, for example, is it a first time implant? Then you should get less infection. If it's a redo, the infection rate is going to be higher. Or if the patient had other circumstances in his comorbidities, you have a higher risk. I think these are the other factors which didn't become obvious in your presentation, but which it's easier to grasp for a simple-minded group in Asia.
So Peter gave a great comment about the patient, the surgeon, high volume surgeon obviously have the less chance to get infection than the patient that don't do the penile implant quite often. This is well documented in many publications. There's no doubt about that. You do more the penile implant you have less chance to have infection compared to people that don't do the surgery often. Unfortunately, in the United States, more than 75% of penile implant surgery were performed by the surgeons. They only do 3 to 4 penile implants per year. So this is going to be reality. And no matter what you say or say, you need to go to the high volume surgeon. But the patient will get a surgery done by somebody who only do less than 4 penile implants per year. Also, those surgeons, in my opinion, they should not even do penile implant if you don't do more than 20 penile implants per year. But the reality is that it's going to happen. A lot of things that, and I agree with you, there's a lot of simple solution, and if you get a surgery done by experienced surgeon, decrease the chance. The problem is, my talk is about in general. My talk is about patient has diabetes. What we can do for anybody here. If you follow all those recommendations here, there's no doubt about that. You're going to have much higher chance to decrease the infection rate. So that is something information of, for your reference.
Okay, very nicely put. Any question? Yes, Simon.
Hi, thanks to all the speakers for the talk, and especially Prof. Lee and Prof. Wang. I have two questions. The first one is regarding the lowering the risk of infection. So one of the problems with us, I mean for me, especially in Singapore, is the nurses that come helping me, they are not the usual regular team. I don't have a regular team to help me. And for that purpose, I feel it's always safer if I prepare the implant myself. I know a lot of surgical team, they try to cut time by getting the nurse or another team, their fellows, to prepare the implant. So I'm just wondering how do you feel about this, having different people preparing the implant for you, where potentially there can be bubbles, air bubble in it, or risking infection in it.
And that's also a very great comment or great observation. And in my practice, I work in 2 hospitals used to be in 3 hospitals. So if I do the surgery in the MD Anderson Cancer Center, I have a wonderful first-class nurse, and I trust her so much. Actually, she's better, much more knowledgeable than my fellow, than my residents. So when I do surgery in that place, I let her prepare everything for me. However, if I do the surgery in surgery center, in one of the other hospitals I used to go, I personally scrub the patient. I personally sterilize the patient before we drape the patient. I also personally prepare for the penile implant. So if I do surgery in those places, it takes me about 1 hour when I make the skin cuts and until I finish. But if I do MD Anderson, and the fastest we did was like 18 minutes. But most of the times we took about 30 minutes. So if you do the surgery under 1 hour, you are perfect. You are, you're doing the perfect surgery. You don't have, increase the chance in terms of the time-wise, for the infection. So yes, what you got, whatever you got. But if you don't trust, if you have any doubt, prepare the device by yourself.
So
That's why I always bring my own nurse in.
lucky you, I don't have one. The second question is regarding what Prof. Lee mentioned, regarding aggressive dilatation and maximal cylinder capacity. Of course, we all try to achieve that for patients to avoid concord deformity and then shortchanging the patient who's not happy with you. But I have seen cases where overzealous or oversizing the cylinder can result in either perforation or like a Z-shaped cylinder that becomes quite floppy. That means when you pump it up, there's a hinge effect that makes the penis droop. So is there any tips or trick how to try to get the best in terms of the girth and the length for the patient?
I'd love to give you some sensible advice, but it's not a technique that I use. The only publication in the literature is Dr. Henry. I think we all try and dilate things as fully as we can, but I think your comment about the potential risk of perforation, both distally, but probably more commonly proximally, is a very pertinent one, and it's one that a complication we wish to avoid. So no, I don't have any tips or tricks, I'm afraid, for you. You need to probably invite Dr. Henry to come and give a presentation at your conference, and he can tell you exactly how he does it. But at the moment, he's the only person in the literature who reports on that approach.
I published a paper with Henry, and I also use the maximum dilatation. I also do the sliding technique with the longitudinal incision, and Iran probably did not get a chance to see my publication. But anyhow, I can tell you that, and I'm the one, I do everything I can to increase or maintain the patient's penile length, because that's our number one. For penile implant business, I don't really know how much more we can improve. I think penile length is always a concern. That's something we needed to do for the years to come to find the best way to improve the patient satisfaction. In terms of the maximum cylinder placement and dilatation, I do dilate as long as I can, comfortably can. I also put a penile implant exactly the same length or half centimeter, even 1 centimeter longer, but I do not use the LGX device. LGX device, to me, to increase the penile length is a mistake. And Iran talking about that does not really, inpatient doesn't really increase the length of the penis, but cause buckling, cause like deformity, even though with LGX versus the Ultrax. So I put a penile implant exactly the same length, or half centimeter, 1 centimeter longer if I have to. And I don't do anything smaller. I think less than 5 centimeter shorter cylinder is a mistake. We don't do that anymore. So if you do that, if you don't use the LGX, you do not get to the situation like what you said. I have never had anybody has perforation or distal perforation from the maximum dilatation, from the maximized cylinder. I have never had one. I only use the AMS, CX, or Coloplast device. So that's my personal experience, and I hope that will help you and build up some confidence to do it.
I mean, I know from what I learned from David Raff was the corporectomy, the site of corporectomy is really quite important to try and put it as close as where the tubing comes out, so that you can get this, get the implant, the cylinder to sit in nicely. And I suspect there's nothing we can do to try and increase the length during the surgery. I think what has to be done is actually before that. In terms of vacuum device or even before all the corporal fibrosis set in from all the prolonged erectile dysfunction. So I'm kind of like guessing it is probably along that line. Akin to what we see in patients who with post-prostatectomy, corporal fibrosis and pro-knees as well.
I think what he said exactly is true, and also around also in a few minutes talked about the all strategy, including pre-op, intra-op, and post-op, and I think that we need to follow all possible, use all those strategy possible safely to to improve as much as we can, because I'm working at MD Anderson. We have so many patients after radical prostatectomy or radiation, they have decreased the penile length, even though we do the aggressive post rehabilitation. But some people, they don't do that. So, and you need to do as much as you can to improve or preserve the patient penile length before you put a penile implant. So I routinely have everybody use the vacuum device before the penile implant for at least 1 month, if they have not done that for a year or two. And also I routinely have the patient cycle their penile implant. We call it the post-op rehabilitation. And after penile implant 6 weeks, I tell the patient pump up daily and maintain erection for about 20 minutes, and for that, do that about 3 to 6 months. And the intra-op, of course, is based on your comfort level. I agree with the comments that you should not do those sliding procedure unless you are absolutely necessary, unless patient understand all those risks, and only do that for the patient has pulmonary disease and has significant shortening of the penis, not routinely.
Thank you, Professor Wang Run. As much as we like to continue with the session, time is running out, and let us give applause to all the speakers, and let us prepare for our dinner symposium.